So I think that takes us on to our Q&A. So I'm delighted that Sean's with us tonight because we've been talking a lot about clinical trials and involvement in PPIE in clinical trials. And this is just one way of PPIE that we happen to have been talking about. And Sean has been a fantastic encourager and slight force of provocation, if you like, to make sure that we stay true to our task and recognise all the different aspects of PPIE. So, Sean, I just wondered if you wanted to speak briefly about some of the ways that you've been involved in PPIE.
Yes, thank you, Hilary. I became involved in the early days because I'd been diagnosed with CLL, but secondly, I'd had a number of issues with family members, and I became very interested in making sure that the patient voice was heard and understood. And I joined our local patient PPG group with our local GP practice. And I found that really quite illuminating because I was involved not only discussing how the practice worked, but at the time the GP practices were obviously affected and managed by some of the local clinical commissioning groups. And I was involved in numerous discussions there. And it was quite interesting that a lot of that was about social care and health care. But a lot of the time, they were just very interested in the patient's view. And I found that very, very interesting indeed, because we were able to contribute. And a lot of the time, many people are very busy and they don't always realize that there is another point of view. So I found that very interesting at the very beginning. As Hilary knows, I'm also involved with a group at Birmingham University, Cancer Research. And essentially, to really cover Jackie's point, a lot of the time, the meetings we have there are to look at patient information sheets and just to look at them from a particular perspective and to make positive, sensible, but practical comments. And over the years, I found that very, very useful because a lot of the time, the researchers and the clinicians are very, very happy. They feel it very valuable that people are prepared to give up their time but make commentary about what's going on. And a lot of the time, it's not got to be incredibly technical or scientific. I think, as Jackie made a point about patients getting to a hospital, the length of time of a journey when they're not feeling very well. Some of them are just points at people who are very busy, have missed out, and they've again been very grateful. So I think a lot of the time it's about common sense, practical stuff, rather than highfalutin technical or scientific stuff. And again, every time I've been involved with this, people have been very grateful. So I'm very inspired by this because I feel very strongly that the patient voice needs to be listened to, and it's up to us to make sure that the patient voice is heard. But at the same time, we have to understand that there are other factors operating on some of these practicalities. So that's really my input into that, if that's okay, Hilary.
That's fantastic. Thank you. So we've got a question here about I'm on watch and wait and supervised by my GP. Would it be too early to get involved in these sorts of activities? What would you think, Jackie?
No, never, never, never. No, you could start just as Sean has done by getting involved with the local community health facilities and things like that. No, never too soon. Honestly, be great.
And I actually am quite happy to disclose that I'm on active monitoring and I'm supervised by my GP. So, and I'm very fortunately haven't needed treatment. And you'll gather I've got rather involved in all this area of activity. So if I can encourage others to do so, that would be fantastic. Somebody's commenting about the challenges of being on a TMG, a trial management group. And are you a patient or are you part of the research team? Where does one end and where does the relationship, where do you sit, if you like, on that group?
I'm very much the patient. We work as a team. We we listen very carefully to each other's point of view, but I am very much the patient. I'm there to put the patient's perspective and the patient's point of view.
And there's a comment here that's saying that sometimes if trials are having a difficult time, that's when patients can be extra helpful.
Absolutely, absolutely. Like I was saying about the trial that was suffering from, difficulties with recruitment, really. It was, some of the things that I suggested, they were like, oh, okay, yes, maybe some of the investigations could be done locally and patients not have to travel, so that then, or that we could, they don't have to have the things done again, simple things like that, really. Because from a patient point of view, you really don't want to go over a load of investigations all over again. Obviously, if it's out with the time frame, then that's tricky. But little things like that can be extremely helpful to researchers to point out.
Sort of assuming that the Research Ethics Committee documents are confidential before their approval, are they available afterwards?
So the documents from the REC application are part of the IRS submission. The participant-facing documents are available certainly to any potential participant going into it, so the information sheet and the informed consent. The purpose of the REC review of all those documents is to ensure that they are fit for purpose. So we may send them back to the researchers and say, we want this written in English, not American English, or we might query something about the level of tests, and doing some of the work that a PPIE group may already have sifted out, but as a second check, to ensure that there is a balance of risk and benefit. So things may alter. So some of the patient-facing documentation may be different at the end. So that wouldn't then be sort of in the general public arena. Protocols, again, it's not that difficult to get hold of a protocol. One could. I think you have to work at that one. They're not generally sort of easily available, and that's true for things like investigator brochures and things with drug data. So it's not that they're secret documents or anything. You wouldn't normally have the the normal documentation of the REC committee, because that's it's under confidentiality as well. So
that's internal. It's the outputs that they then approve that are the externally available ones. Okay, thank you. And there's a question here about for Nick. Wonder if you can help with this one. Are CLL studies following the scientific changes, or has there been any sort of, well, it says JLA. I gather that's a ranking type exercise.
It has to be a combination of both, doesn't it? We obviously have to follow the research developments. Otherwise, the studies will quickly fall out of validity, and they needs to, and will lose attractiveness for funders, really. So I don't think they can lose touch with what was there in sort of at the front of the wave of scientific development. There's definitely instances where I've seen prioritization exercises that have been done with patient representatives in order to identify research questions that can be asked or addressed first, or as a priority for certain studies based on the patient's input. So the short answer is probably yes to both.
Thank you. And sorry, Ben.
Yeah, I was going to say, and it sounds like the James Lind Alliance, which we've spoken about before in terms of setting.
Mm-hmm. Yeah.
So which is a very sensible way of sort of having a structured approach to priority setting for research questions. So I think that's really what a good PPIE group is trying to sort of get at in a sensible way, working collaboratively with researchers to ensure that research is supported, and also speaks to the priorities of the patient group. So it's I'm sure the answer is yes, but it needs to be worked on and introduced, and that relationship needs to be set up, and that's what the PPIE group is for.
A couple more questions. Do we need special training for a data and safety committee? I don't know who mentioned the data and safety committee. Was it you, Ben?
It was me. Yeah, it was me.
Oh, was it you, Nick? So
No, it's all. You don't have to. You're just reviewing adverse events, etc. And I think that one of the things to highlight here is that as a patient representative on a group where you will see some information that might not be as familiar to you, because it's a little bit technical, a little bit medical. We're very happy to see a person that is engaged to say, hold on a minute, can somebody pause and explain this to me a little bit better, because I'm not quite getting this quite. And we're very, at this, in this situation, the clinicians can tell you 100%. They'll take the time to pause and explain things clearly, so the person who's there representing the patient understand what's going on, etc. So no specific training.
So it only remains really for me to say thank you so much to Troy and Sean and Jackie and Nick and Ben, and to all of you on the call. And to say, Jackie, thank you so much for your comment when you said that if people get involved in PPIE, the CLL community generally will be indebted to you. I think it's really important that this gives us an opportunity to make a difference. But on the other hand, we need to be careful not to do anything that we feel awkward about ourselves. So the duty of care to ourselves as well.